Okay, let's unpack this. There's a number from mid-2025 that really stands out in the material you've shared, and honestly, it feels pretty stark. We're still seeing, what, around 300 to 350 COVID-19 related deaths every single week here in the U.S.
Yeah, it's surprisingly persistent.
Right, that persistent reality is kind of the core puzzle we're diving into today.
Yeah.
And this deep dive, it's built entirely on your sources, the articles, the research, your notes. Looking at the U.S. COVID situation, these big recent policy shifts and how it stacks up against other countries. Around May, June 2025, our mission really is to cut through the noise, understand the key factors keeping that number, well, stubbornly high, explore what the policy changes mean, see the global contrast, and highlight what the experts in your material are actually saying.
And what's fascinating, I think, is that the number itself, those 300 to 350 weekly deaths, it means COVID-19 is still a leading cause of infectious disease death in the U.S., even now.
Yeah, exactly. It's not some minor issue based on those figures.
Not at all.
Okay, so setting the scene. U.S., May 2025. That death rate is our starting point. And the sources you've got point to several things driving this, right? They're kind of interconnected.
Exactly. First off, the virus isn't, standing still. It's evolving. The material highlights new variants popping up, specifically NB.1.8.1.
Right, the Omicron descendant.
Yeah, a descendant of JN.1. It apparently originated in China, and by mid-2025, it was found in several U.S. states: California, Ohio, Rhode Island, Hawaii, Washington.
So spreading, is it more severe?
Well, the notes say it's more transmissible, spreads easier, but it doesn't seem to cause worse illness than the ones before it.
Okay, so it's still circulating effectively, just finding people. What else is keeping those numbers up?
Waning immunity is a big one, just, across the population. Protection from having had COVID before or from the vaccines, it naturally goes down over time.
And if you combine that fading immunity with, well, not many people getting the latest shots, that sounds tricky.
It absolutely is. The research you provided has specific numbers for the 2024-2025 vaccine season. Only 23% of adults 18 and up got the updated vaccine.
23%. Wow.
And for kids, even lower, just 13%.
So that leaves, most people without that latest protection.
A huge majority, yeah.
And it's not just prevention, right? Your notes mention treatments too. Even the effective ones aren't always getting used.
That's a critical point. We have antivirals like Paxlovid, Molnupiravir. They're available, and they're proven to work really well at reducing severe illness if you take them early, like within 5 days of symptoms starting.
But people aren't getting them in time.
Seems that way. The reporting suggests many aren't accessing them quickly enough, or maybe not at all, for whatever reason.
And if we look at who is most affected by these ongoing deaths, your sources point to a specific group, don't they?
Yeah, the high-risk groups are still bearing the brunt. Older adults especially, particularly those 75 and older, they have the highest death rate. The material notes it as 4.66 per 100,000 people.
There's a quote in here from Dr. Tony Moody at Duke. Pretty straightforward take.
What does he say?
He basically just notes that the fact that people are still dying shows the virus is, well, still very much circulating and infecting people. Simple as that.
That's a stark reminder.
Right. And here's where it gets really interesting, because this picture you've laid out for the U.S. ties directly into some major policy shifts happening right around then.
Yes, absolutely. The overall strategy from the U.S. government clearly shifted, moved towards a more limited, risk-based approach.
Less broad mandates, more personal choice.
Exactly. The emphasis definitely shifted to individual responsibility. And as your sources point out, this change in thinking really kicked off a lot of debate among public health folks and policymakers.
Understandably. So what were the specific changes? Your material details quite a few, starting with vaccines, recommendations, and access.
Okay, so there was a big announcement, May 27th, 2025. HHS Secretary Robert F. Kennedy Jr. stated the CDC would no longer recommend COVID vaccines for healthy children and pregnant women.
No longer recommend them at all for those groups.
For healthy children and pregnant women, yes. And this was flagged as a major shift from prior guidance. And apparently, it was done without the usual process, involving the CDC's expert panel, the ACIP.
The Advisory Committee on Immunization Practices. They usually weigh in first, right?
They typically review all the evidence and vote on recommendations before the CDC makes them official. Skipping that step was noted as, well, unusual.
It seems significant. What else on the vaccine front?
At the same time, the FDA updated its guidelines. They limited access to seasonal boosters for healthy people under 65.
Limited access,
Well,
meaning they couldn't get them.
essentially, yeah. The rationale given was a lack of clear clinical benefit for that group based on the current data. So boosters became primarily targeted, aimed at people over 65, and then anyone 6 months or older who had specific high-risk conditions.
Okay, so recommendations pulled back for some, access limited for others. And it wasn't just vaccines. There was big restructuring within the health agencies, too.
Yeah, HHS, the Department of Health and Human Services, went through a major reorg back in March 2025. They created this new entity, the Administration for a Healthy America. But the really key part, big workforce cuts.
How big?
The material suggests around 20,000 employees were cut across HHS, with specific hits noted at the CDC and the FDA.
Wow, 20,000 people. From the CDC and FDA, among others.
Yeah, the scale of those cuts, especially hitting key public health agencies so quickly, is definitely a major point raised in your sources.
Losing that kind of expertise and manpower from the agencies meant to track and fight health threats? That seems potentially problematic.
It raises questions about capacity, for sure.
And then there was the international angle, the WHO.
That's right. President Donald Trump signed an executive order 455 back on January 20th, 2025. And that order officially started the process for the U.S. to withdraw from the World Health Organization.
And the reason given.
The stated rationale involved concerns about how the WHO handled the pandemic and issues with its governance structure.
Okay, so we've got this new landscape then. Fewer government vaccine recommendations, limited booster access for many, major staff cuts at health agencies, and leaving the WHO. This really brings up a critical question, which your sources get into. What are the potential impacts, the consequences of this whole approach, according to the experts you looked at?
Well, the concerns that come through in the material, especially from medical experts, are pretty serious. One big one is increased vulnerability in specific groups.
You mean like the healthy kids and pregnant women, the ones the CDC stopped recommending vaccines for?
Precisely. Experts worry that pulling those recommendations could directly lead to fewer people in those groups getting vaccinated.
Makes sense.
And the downstream concern is that lower vaccination rates could mean they're more susceptible to getting infected, maybe higher rates of hospitalization or even mortality in those groups compared to if the recommendations had stayed.
Huh. It sort of loops back to that starting number, those weekly deaths, suggesting maybe those groups could become a larger part of it.
It's a potential risk they highlight, yes.
What about the public health system itself, those agency cuts?
Yeah, the worry there is that those big staff reductions at HHS, CDC, FDA, they could seriously hamstring the government's ability to do its job. Tracking disease spread, spotting new variants quickly, mounting a fast, coordinated response if something new pops up.
So it weakens the overall defenses.
That's the concern. If we connect this to the bigger picture, a weakened public health infrastructure just makes the country less ready for any infectious disease threat, not just COVID.
And there's also a practical worry about, cost and access for regular people.
Yes, that's a key point raised. With the CDC officially not recommending vaccines for some groups, there's a real concern that insurance companies might look at that and say, okay, we don't need to cover it for them anymore, or maybe cover less.
So it could suddenly cost people money out of pocket.
Potentially, yeah. Higher costs, reduced access. It could make vaccination a financial decision for some instead of just an easily available health measure.
It sounds like overall, the health professionals cited in your sources are worried this whole direction could sort of undermine public trust, make it harder to get people on board next time there's a health crisis.
That's definitely a thread running through the concerns, yes. Eroding trust in official guidance could have long-term consequences for public health efforts.
It really paints a picture of potential challenges ahead based on these changes. But the material you pulled together doesn't just focus on the U.S. It gives this really fascinating contrast, looking at what other countries were doing around the same time, mid-2025.
And the difference in, philosophy and just the practical approach is pretty striking. While the U.S. moved towards limiting access for some, pulling back on promotion, many other countries are actively, very visibly encouraging vaccination for broader groups.
Okay, let's run through some examples you found. Canada, for instance.
So in Canada, the federal and provincial governments are actively promoting seasonal boosters, and not just for seniors and the immunocompromised, but explicitly including pregnant women and children.
So the groups the U.S. stopped recommending for.
Exactly, and they back it up with public campaigns, TV, digital outreach in communities, and the shots are free everywhere.
Okay. How about the UK?
The NHS, their health service, runs targeted seasonal campaigns. They focus on the 75 plus people in care homes, and the immunocompromised. And they use things like mass text messages, social media, trying to get people to book their appointments.
Australia is another one you highlighted.
Yeah, state health departments there, like in Queensland and Victoria, are strongly urging people to get boosters, especially the elderly and vulnerable. They mention it's particularly important with variants like NB.1.8.1 spreading. Vaccines are free, easy to get, advertised heavily in pharmacies, clinics.
Are they seeing issues?
They're apparently issuing public warnings about hospitalizations going up, specifically among older folks who aren't vaccinated.
What about France or Singapore?
France has government booster campaigns, oftentimes before, say, flu season or big travel times. They push it for high-risk groups and the over 65s through pharmacies, online health portals. Singapore is really proactive. Consistent government advice for everyone eligible to stay up to date. Easy access through clinics. Text reminders automatically sent out. Very systematic.
And South Korea.
South Korea uses centralized reminders, convenient walking clinics, and their public messages often stress protecting not just yourself, but family, society, especially when new variants are surging.
So the material you gathered actually lays this out side by side, right? These different approaches.
Precisely. It draws a really clear contrast. Like on vaccine promotion, you've got active public campaigns elsewhere versus basically no national promotion and polled recommendations in the U.S.
And the target groups.
Much broader elsewhere, seniors, pregnant women, kids, wider at-risk definitions, versus the U.S. focusing narrowly on just seniors 65 plus and the immunocompromised.
Government messaging.
Described as pretty consistent, science-backed internationally versus seeming more politicized and fragmented in the U.S. at this time.
And access.
Generally free and widely available in those other examples versus potentially depending on insurance and maybe harder to get for some in the U.S. And finally, public trust in health agencies seen as generally stable elsewhere but declining in the U.S. due to these policy shifts and the agency restructuring.
Wow. It's such a clear split in strategy, and I guess the philosophy behind it. What does seeing that global contrast tell you about the choices being made here? Your sources kind of synthesize this by bringing in experts from places like Johns Hopkins, Imperial College London.
Yeah, and those experts generally express, well, caution about the U.S. approach to this more hands-off, minimalist strategy.
Yeah.
They think it carries real risks, like potentially lowering overall immunity in the community.
Which could let variants spread more easily.
Exactly. Allow variants to spread more quietly, maybe under the radar. And the ultimate fear is that this could lead to more deaths long term, especially in vulnerable groups who might fall through the cracks of a less proactive system.
And what's their take on the countries doing more outreach, keeping vaccination broad?
Their assessment seems to be that those countries, the ones still focused on proactive outreach, easy access to vaccines, investing in public health, they're just, well, better positioned, better equipped to handle surges, new variants, to lessen the blow in terms of hospitalizations and deaths.
So what does this all mean when we look at these different paths? The experts you cited, they seem to be pointing towards the potential benefits of doing things differently than the current U.S. track, like the alternative policies mentioned.
It seems that way. They implicitly support some of those alternatives discussed in your material.
Like maybe going back to broader vaccine recommendations for everyone eligible.
Yes, the idea being that reinstating evidence-based guidance for all groups, including healthy kids and pregnant women, could really boost community immunity, help reduce the overall impact of the virus.
And what about shoring up that public health infrastructure after the cuts?
Absolutely. Investing in agencies like the CDC and FDA, keeping staffing levels up, ensuring funding is seen as crucial. You need a strong system to actually monitor threats and roll out strategies effectively.
Makes sense. You need the people and resources.
Right. And the third piece is connecting back internationally.
Rejoining the WHO.
Rejoining and actively participating. It's seen by these experts as really important for sharing information globally, coordinating on surveillance, and just having a more unified front against pandemics, which, don't respect borders.
So these alternatives, broader vaccination guidance, stronger agencies, international cooperation, they're framed in your sources as ways to directly counter the risks seen in the current U.S. approach.
That's the connection they seem to be making, yes. Addressing the potential downsides of the more limited strategy.
Okay, so to wrap up this deep dive, we've looked at how the U.S., even in mid-2025, is still dealing with this steady concerning number of COVID deaths, driven by things like variants, waning immunity, low vaccine uptake. We unpack that big shift in U.S. policy towards a more individual, risk-based approach, changing vaccine guidance, cutting health agency staff, leaving the WHO.
Mm.
And we contrasted that starkly with other developed nations that are maintaining much more proactive public health strategies,
Mm.
broad vaccination campaigns, strong messaging.
And highlighted the expert concerns about what these diverging paths might mean long-term for vulnerability, for preparedness, for public trust.
Right. So the final thought, really, for you listening, what does this deep dive into your sources make you think about these very different ways countries are choosing to live with this virus now, and what those fundamentally different choices might mean down the line for their people and their ability to handle whatever health challenges come next? Thank you for bringing these sources for this deep dive.